Welcome, everyone. I think Anand and Rena, it's so interesting that at two separate events this year, you both use the same phrase that we are living in unprecedented times when it comes to medical care in the United States. And Rena, you said because cures are coming faster than ever before. And Anand, you said because for the first time in 100 years, we've had 3 consecutive years of decreasing life expectancy. Now, I know a number of factors came into play, including the opioid crisis, but I really think that sets up our discussion today, and that is how do we make sure that these extraordinary cures and innovations are accessible and are actually lengthening our lives and making us healthier? Anand, do you want to start?
Sure, and I want to thank Atlantic for organizing this very important forum. And I think, Kathleen, I think we have to do both. We have to be able to invest in innovation at the same time, expand health insurance coverage, and ensure that Americans across the board have access to important therapies. And I guess the question is, what makes me confident that it is possible? I think it's important to look at sort of a recent paper in JAMA that looked at waste in American healthcare. Sure, we spent $3.6 or $0.7 or $0.8 trillion dollars on healthcare in America, 18% of our gross domestic product, but it's estimated that 25 to 30% of those dollars don't go to improving health outcomes. Just imagine what we could do if we could redirect some of those resources, whether it's to other sectors of society, whether it's to pay down debt, or whether it's to invest in innovation to ensure that Americans get access to all the evidence-based health services that they need. So I do think it's possible in this country to do both invest in innovation as well as ensure that Americans have access to these therapies.
Rena and Josh, we started out the morning talking about prescription drug pricing. Would you like to share any thoughts? I didn't know if you had any comments on what the congressman said regarding H.R. 3 and the long-term and the short-term impacts, if that measure were to pass, but of course he says it's dead on arrival.
So it's clear that there's bipartisan support to improve the affordability of drugs in America, particularly for those who are underinsured or who are living on fixed incomes. So whether it's H.R. 3 or the Senate Finance Bill on drug reform, it's clear something will happen, or at least the stakeholders are very focused on addressing those issues. Whether or not the more controversial parts of the bill, which include both inflation penalties but also negotiation for drug pricing directly between the government and pharmaceutical companies, becomes a reality, we'll see. But certainly addressing affordability for fixed income, for seniors and other folks living on fixed income has to happen.
Yeah, I mean, I think that right now there's such momentum from a public debate standpoint that there's going to be something that's going to continue to be a high priority. We know that about 40% of people are skipping treatments of some sort because of the cost of care, and so that's obviously high on the minds of people right now. How that translates into something getting done in the current political environment, I think, is another question.
Josh, I wanted to stay with you because one of the measures in H.R. 3 is using an international price index. And some critics of it say that can end up having this sort of circular effect where countries are looking at what other countries are doing instead of really looking at the cost. Basing it on concrete measures, basing the cost of the drug on the concrete measures of the medicine's clinical value or the cost of developing it and producing it.
Yeah, I mean, I think we have to get to a point where we are basing costs of care on the benefits that they produce and getting to true value. We're obviously changing how we think about payment in general from a fee-for-service to more of a value-based payment environment. In that context, what the value of these various treatments are, and in doing so, we have to get to something that's based on the best evidence we have. Now, I will say that one of the challenges is that in some cases, the evidence that's being used is based on not sort of the full range of information that we have. So we need to think about more creative ways of understanding evidence, thinking about the use of real-world evidence, collecting data across what's going on in real-world settings, making the most of information systems and sharing that information that we can to get better information to answer those questions.
Anand, can you help us understand what some of the cost drivers are? So we're looking at affordability and access. I mean, you, obviously you're an internal medicine physician. You served in the Obama administration. So you've really seen this at HHS. You've seen this from both the public and the private policy side. So what are your thoughts on what the drivers are and how we can improve access?
Yeah, sure. So when you think of access costs or waste, you think about administrative complexity in healthcare in this country. You think about fraud and abuse. You think about pricing failures. You think about failures of care delivery, care coordination, overtreatment. There are many areas where there are access costs, I think, in our system. If I can piggyback on Josh's comments sort of about this important term value, I think how we incentivize innovation to address some of these issues are critical as well. So in this country, we prioritize safety and efficacy as we should. We have a regulatory pathway through FDA. We prioritize reasonable and necessary. We have a regulatory pathway for CMS, public payers, and private payers. What we don't have is what is happening in clinical settings every single day. Right now, thousands of patients and clinicians right now are having a conversation where there are FDA-approved treatments for a particular illness. They're paid for by an insurance company, but the clinician and the patient don't know which treatment is better than another. And that means we need to invest in this country in health services research, patient-centered outcomes research, comparative effectiveness research. Frankly, reauthorization of PCORI is one of the most important things Congress can do this session. But we need to ensure that patients get the right treatment, that the right treatments go to the right patients at the right time. And we'll only be able to do that and allocate our resources appropriately if we can get that information in the hands of patients as well as clinicians for shared decision making. So I think that's sort of one strategy. And we need to incentivize that type of innovation in the same way we value safety and efficacy. We need to incentivize sort of comparability as well as effectiveness. And if we can do that, I think the innovations that will come through will be that much more promising and will be, I think, accessible for more Americans.
Why is that not happening right now?
Well, I think to a certain extent, there is information about that. There's public sources of funding for that information. There's private sources. Some of this is proprietary. Some of it's not transparent. In some cases, it's not in the best interest of an entity, right? If you're manufacturing a particular product and another product is better, that might not be the best thing for your bottom line. So there are inherent difficulties right now in ensuring this important information gets into the hands of clinicians and patients. We need to surmount those barriers. We need to invest in this area. That will help our whole innovation pipeline. Because we'll then be creating innovations that are really true innovations that can be accessed by patients.
You know, Rena, at the Institute for Health System Innovation and Policy, you gather together these teams of interdisciplinary experts, and you are working to study and shape U.S. health policy. What are you finding when it comes to better aligning the public sector and private sector to bring these breakthrough treatments to market, but then make them affordable to the payer and the patient?
Sure. So we have two ongoing activities at the Institute right now that are very exciting. And I like to think of them as being financing innovation. So the first is about incenting innovators to invest in therapies that we know have a great unmet need. Specifically anti-infectives, including antibiotics, that we really need more of, and that we are finding innovators not invest in because the economic incentives at this current place are not there. And so we have a full public-private partnership where we are pulling innovations into the anti-infective space. Secondly, I am leading a team in the state of Louisiana that is partnering with innovators, specifically Gilead, to essentially create a volume-based contract with the innovator to bring new drugs that treat and really cure hepatitis C to the population.
That's fascinating. It's like a subscription model, like Netflix or something, right?
Right. So the idea is that is really what Walmart does. So essentially, we are committing. The state is committing to finding and treating folks, and in exchange for a volume, a quantity guarantee, they are getting a very deep discount on the drugs. So
And a cap on what they spend, correct?
that's right.
Very exciting. Josh, you have been at Avalere working on something called the value frame, here it is, the patient perspective value framework. Help us understand what that is and how it's making a difference.
Yeah, well, there are, in around 2015, there emerged many value frameworks, ICER and ASCO and others came out with these value frameworks, and it's as I was saying before, we need to be able to understand value in order to make sort of evidence-based decisions about what makes sense in a world of limited resources. I think what we have found is that we're not always taking into account value through the lens of the patient. And the idea here was to develop a framework that started with what really matters to patients and thinking about how to value treatments in that way. Now, we're not creating a framework that's going to, compete with ICER or something. What we're trying to do is create specific methodological and technical recommendations that can increase the patient orientation of frameworks like ICER. And so that is being used in a couple contexts. One is to make those specific technical recommendations, and the other is to really support what Anand was talking about related to shared decision making. So what we also know, one of the reasons that's not happening is that people are not having those conversations in a structured way. And so how do we use this kind of information to really guide patients as they kind of go through their care journeys, particularly when they are facing very serious health issues?
Anand, when it comes to incentivizing innovation, you've talked and increasing access. You talked about cracking down on waste. What about unfair practices like patent abuse? How important is that? And what other measures do you see that we could use to really incentivize innovation?
Well, I think we need to always incentivize innovation. At the same time, we need to ensure that while we incentivize innovation, that there are not abuses. And I think ultimately, whether you look at patents and evergreening and patent abuse and patent tickets, we need to make sure that at the end of the day, what we're not doing is stifling competition and just raising prices and then reducing sort of the accessibility and the affordability is what we want to see. So I think we need to be balanced in our approach, and I think we need to look holistically. I think in terms of sort of pushing forward sort of innovation in the pharmaceutical space, I think we need to continue advancing all of the innovative models out there. Rena's mentioned the subscription model. Josh has talked about value-based pricing strategies, indication-specific pricing. We'll have a paper, Kathleen, on Tuesday coming out of the Bipartisan Policy Center looking at pharmaceutical reference pricing. That's both internal reference pricing as well as external reference pricing, which is really the basis.
Explain to us what that means.
Yeah, sure. So external reference pricing, as you heard from Congressman Walden, is essentially using other countries' prices as a benchmark potentially for our prices in this country. That's the basis of President Trump's IPI proposal, as well as Speaker Pelosi's H.R. 3, an international pricing index is the backstop of the negotiation process. So we look at external reference pricing. Then we also look at internal reference pricing, which is essentially if we can determine drugs are therapeutically equivalent, probably ought to be paying the same amount for those drugs. If you have two drugs that are equivalent in terms of clinically from an outcomes perspective, and one is priced here and one's priced here, maybe there's something wrong and maybe there's something we can do. And so,
well, what could we do
sure.
to bring that price down from the higher one?
So that there are lots of different strategies, and public and private payers have looked at these. Medicare used to use what's called the least costly alternative. So if you have essentially two drugs, same effectiveness from a therapeutic perspective, one priced here and one priced here, that maybe CMS ought to pay for the least costly alternative, LCA policy. There are lots of different ways, but it all depends on ensuring that you have a data and research infrastructure in this country that can ascertain and determine therapeutic equivalence in a way that all stakeholders can agree upon. And that gets back to the importance, again, of having patient-centered outcomes research and comparative effectiveness research, getting this information out there for patients and clinicians for shared decision-making, but also then policymakers can make the best decisions in terms of how do you increase access.
Rena and Josh, I see you nodding. Do you want to jump in?
No, I mean, I think that we need a lot more evidence regarding what is the value of these products and how should they be best used. And that includes both clinical benefits, but also other benefits, which include people being able to work and take care of their families while they're undergoing therapy. Right now, we know something about the clinical benefits, at least in the short term, but gee, we really want to know there's other benefits as well in order to choose the best option and really to use our resources as wisely as possible.
I think that there's another component to this. I agree with everything that Anand was saying, and Rena. I think that there's also a practical at the point of care issue, and we've been working with the Robert Wood Johnson Foundation for the last 4 years on trying to normalize cost of care conversations in the clinical setting. Because typically, or historically, doctors probably, you probably say, I didn't go to medical school to talk about cost with my patients. I'm trying to find the best clinical alternative for my patient. But we know, as I said before, that 40% of patients are forgoing treatments because because of the costs of care. And so we have to be sensitive to that. And that means that it does become the job of the clinician to be mindful of that, particularly for people who have increasing copays, deductibles, increasing financial burden, and financial responsibility. So trying to come up with, once there's sort of established that we should be having some of these conversations, coming up with the right tools to support that, then trying to figure out how to integrate that into the clinical workflow. And then the last piece of this, which is what we're working on right now with the foundation, is how do you measure that and hold providers accountable for having those conversations?
Anand, I wanted to circle back around and talk a little bit more about patents. The congressman mentioned that his committee, their committee, had passed some measures, including ending one that would have ended pay for delay. They didn't end up ever making it to the Senate and getting a vote. I mean, how concerning is it that measures like that could have made a difference didn't really get anywhere? And then when we talk about patent abuse, how concerned are we about what goes on in China every day when our drug manufacturers go over our pharmaceutical companies to make their drugs there? And China says, well, sure, as long as you give us all your trade secrets, tell us how it's made. And they force this on them.
Well, I would say I think there are probably some low-hanging fruits, whether it's pay for delay or the CREATES Act, that many of us have been talking about for quite a while, where there is some bipartisan agreement, and you'll see elements of these provisions in many of the bills in the House and the Senate. And so if something actually does come to fruition in terms of policies to increase affordability and accessibility of drugs, I suspect you will see some of that, some of those low-hanging fruits cross the finish line. I think in terms of, again, patents more broadly, we need to do what we can to protect intellectual property. I think, but here the conversation is ensuring that the incentives and the rewards for innovation are commensurate with the value of that innovation as well, and ensuring that the rewards are really for the innovation and not just to stifle competition. And that's often a very difficult line, but I think it's an area that we're all learning a little bit more about, and I think policymakers are as well, and ensuring that we're getting that important balance correct.
Rena, go ahead.
Yeah, I mean, I think that this is a win-win. It's clear that this is great for patients because more competition, lower costs, greater availability, and frankly, it frees up resources in our system to be used for the next great thing that actually is going to alter the trajectory of our lives. So I think we all recognize that that improving competition, regardless of where you are in the political spectrum, is a really good thing to do, and it really is not going to stifle innovation. In fact, it may even pull more innovation out there.
Josh, on the subject of value frameworks that, that we were discussing earlier, obviously, as important as they are, when they come out with their results, they can generate controversy. And ICER did this week. ICER, for those who don't know, being the Institute for Clinical and Economic Review. And their report last week found that the prices of 7 top-selling pharmaceuticals in the United States that went up fairly dramatically in 2017 and 2018, the prices went up despite limited evidence that patients using them experienced greater benefit. So how concerning is that?
Yeah, well, I think, again, it's getting back to ensuring that we are getting to sort of a full review of the evidence. And again, that evidence needs to, one, include the views of everybody affected by it. So particularly really understanding what are the sort of patient views of value and ensuring that we're measuring that. And then the second piece is ensuring that the data that we're using are coming from sort of the full range of sources. We need to be able to tap into, so when we're looking at evidence, we're looking at studies that have been published some time ago, and we know about the chain of events that leads to data getting into the published literature. There is a much broader array of evidence that we could be tapping into to really get to sort of full, up-to-date information related to that.
Rena, backstage we were discussing, as we're talking about access here, the situation that's come up, really coming to folks' understanding this week about the childhood cancer drug vincristine, where one of only 2 manufacturers, Teva, has stopped making it. And now physicians around the country are realizing they may not have this vital drug that they need to save the lives of millions of American children. So what are your thoughts on that? What are we doing to stop that from happening with more and more vital drugs?
Yeah, so 90% of all drugs that are consumed in the United States are generic. They're off patent. And the vast majority of those products are not made domestically. They're made in the international supply chain, largely in India and China. My work and many others have suggested that the supply chain is actually quite fragile. And that's because for many of these backbone therapies, there really is only one manufacturer, or maybe 2, that is actually supplying those products. So when quality problems happen, or there's unexpected environmental challenges, such as hurricanes or typhoons, our supply of these products can actually be quite interrupted or fragile or vulnerable. So what do? These type of quality problems or supply chain vulnerabilities have been emergent for at least the past 10 years. There are shortages of other very important backbone therapies that the system has learned to deal with over time. The FDA is well aware of this, and they have done a really great job. They have reduced barriers to entry and supply so that they make sure that products that can come to market do come to market to relieve potential shortages. They've also really worked with the manufacturers to make sure that when manufacturers are experiencing quality problems, they really work through them, and that doesn't really actually threaten supply. And then, frankly, there are new ideas out there about what else we could do, which might include shoring up some of the domestic supply of these products, or finding other partners that can manufacture these products at the same high quality standards and safety that we're used to.
Thanks, Rena. Well, let's go to our audience for questions now. Any questions from my terrific panel? And we have one right up here in the front. And if you would stand and identify yourself, here comes the mic.
Good morning. I'm Kim Zabarik with the Cancer Support Community, and addressing the concerns of having patient perspective included. To date, patient experience data is not required to be collected in clinical trials. Could you all speak to that and a path forward where the collection of patient experience data, including psychosocial, would be required?
Great question.
Yes, we need that information. So there are folks out there, they'll say, well, the state of the science of how we actually think about those measures still needs improvement. Sure, we're all learning how best to measure those things, but that should not be an excuse or a barrier to actually start collecting quality of life and other measures for folks with cancer who are undergoing clinical treatment and others as well.
Yeah, related to the Patient Perspective Value Framework Initiative that I mentioned, one of the things that we worked on over the 2018, early part of 2019, was a set of global recommendations related to how to increase the patient orientation of existing value frameworks, something that we worked on with some other value framework developers, including the American Society of Clinical Oncology and the National Comprehensive Cancer Network. That work we published on our website. It's available, these global recommendations, which include things like what you're talking about. And that was published in May of 2019. It's on our website.
Right. And we had a question right here in the front, if our mic runner wants to come back. She's getting her exercise today.
Thanks. Hi, Joyce Frieden, MedPage Today. I wanted to ask Mr. Seidman to expand a little on what he said about providers possibly being held accountable for having those financial conversations with patients. What form do you see that taking, and have you talked to any providers that are willing to do this?
So this is sort of the next phase of this work on cost of care conversations that we've just embarked on with the Robert Wood Johnson Foundation. We literally kicked it off 2 weeks ago. So we're still in the sort of process of identifying through an environmental landscape everything that exists that we might draw on. We think that there's sort of likely two kinds of things that we'll need to create. So one would be new actual measures, and these could be performance measures, quality improvement measures, things of that nature. The second would be tools or toolkits or resources that can be provided alongside that. We don't want to just sort of create a set of expectations around accountability without providing some guidance for how to get there.
Anand, as a physician, would you like to have the last word here on that?
I think, Josh is right. In medical school 20 plus years ago, we didn't really learn anything about sort of the cost of care, and I hope things have improved 2 decades later. But I think all of these conversations are important. They're all teachable moments. I think we can't shy away from having conversations about costs. I think we all need to learn more about this, and in our particular settings where we work, and whether it's a clinical setting or not, I think we need to have these conversations, because at the end of the day, we're here for our patients and our citizens, and this is important to them. So it's important that we're informed about these issues.
Well, please join me in thanking my wonderful panel, Anand, Rena, Josh.